Hi, my name is Aaron Bleznak, and I am fortunate to be a member of the Commission on Cancer 100th Year Anniversary Celebration Committee. And in that capacity, it is my great honor and privilege to be speaking with Dr. Glenn Steele, who was chair of the Commission on Cancer in 1990 to 1992. Dr. Steele and I have a little bit of a history together, probably most significantly when he became CEO and president of Geisinger Health System, and I was an associate in surgery with Geisinger. But he has had an extremely fruitful and impactful career. And so I'd like to ask him initially about his years as Commission on Cancer chair, and then give him an opportunity to provide us all with his perspective on healthcare specifically as it involves the realm of cancer. So Dr. Steele, welcome.
And thanks very much. Thanks very much, Aaron. It's great to be interacting with you again. Brings back great memories about our time together at Geisinger, and certainly being asked to comment on my time at the commission is it's an amazing honor. That was it's just barely in my memory bank, but it was a wonderful time. So fire away.
So Dr. Steele, what initially led you to engage with the Commission on Cancer and led to your becoming chair from 1990 to 1992?
Well, you know, it's really interesting, but when I first started my professional career, it was at the Brigham, and I was assigned with a wonderful colleague, a guy named Bob Osteen, to be the Brigham surgeons at the Farber Center. And it was just at the beginning of the Farber Center. It's before it had developed a huge amount of clinical credibility. It already had research credibility. And it was a perfect time for us who were focusing on cancer as our specialty, because most of the clinical trials up until the late 70s and in through the 80s had never had surgical leadership. I mean, despite the fact that surgery was the single most effective modality, all these multimodality trials were just suddenly for the first time discovering that surgical quality was as important as what, chemical you added to the mix, either pre or post-op, or what radiation therapy. And so I got involved in surgical quality control, basically as the first and major input to the multimodality clinical trials. And we discovered that, surprise, surprise, when you created specifications for how to do the surgery, it had an impact in outcome. And that impact was quite separate from whether the chemotherapy worked or not. And that, and the commission at the time was in a perfect position to scale those new findings. And I had a personal relationship with Dave Winchester. Dave was a part of the American College of Surgeons leadership at the commission. The commission obviously was the ACS plus the American Cancer Society. So it was just, that's how I first got involved, Aaron. And, and I didn't come in as a leader. I came in as a schlepper. But that's how we all start, right? We all start as schleppers. So,
so do you, thinking back to 1990 to 1992, can you think of any or recall any major challenges the commission was facing at that time?
Well, there was in surgery in general, there was just the beginning of a move to credentialing. And I was also chairman of the American Board of Surgery for a couple of years. And, the balancing act there was to keep general surgery together as a holistic, but not hinder special certifications that were occurring. I think it occurred first in vascular, and then it was starting to occur in oncology. So the college was just another extraordinarily important venue where the right balance could be could be achieved. And the commission obviously was an important part of that in cancer. So that was number one. Number two, the commission, particularly because of its relationship between the college and American Cancer Society, was a perfect way to incubate leadership, surgical oncology leadership. Part of it was networking, part of it was, getting to understand how you participated appropriately in multimodality trials. And the third thing, of course, was, the commission was the credentialing for the registries, the tumor registries. And at that time, for many, many hospitals, the tumor registries were the key and most important aspect to actually ensure quality and to try to plan prospectively what the optimum treatment would be for, patients with relatively straightforward cancers or patients with complex cancers. So it was absolutely critical, and all that stuff was in was in a tremendous dynamic period back in the 80s and the early 90s.
So I don't know if you are aware of the Surgical Standards Committee that has now been created under the Commission on Cancer, and the textbooks that came out, which I think dovetails very nicely with what you were thinking, although you probably think that we should have been doing this 2 decades ago as opposed to now.
Well, no, I am aware, and I think it's a direct consequence of what the commission stood for, and I think the commission should feel extraordinarily proud of that as its output. I mean, the other thing, quite frankly, that I know David and I and a couple of other people were really, really focused on was the National Cancer Database. And, I've had a lot of positive feedback about my time at Geisinger. I've had a lot of positive feedback about my early involvement in multimodality trials. And I think one of the most significant things that came out of the commission was the NCDB and the ability to use those data to understand, just how much variation there was in optimizing care, just to see what the lag time was in various markets, various parts of the country, and with various diagnoses, between a new discovery and then the application of that new discovery into best practice. I think the NCDB was a very big deal, and we should feel very proud of that. I certainly personally am proud of that.
I think that I don't know how much has been communicated to you, but we are now moving to looking at this large number of metrics and reducing the lag time as quickly as programs can abstract it. We can give them back their data.
Well, there was a lot of patronizing about the NCDB from the SEER guys and girls, because SEER at the time was the only major national data, and yet it was obvious. Again, this is not meant to be too parochial, but it was obvious that cancer treatment, the non-liquid cancers, was still most beneficially affected by surgery. And for surgery not to have its own leadership, for surgery not to be able to have its own national data, for surgery not to be able to do its own analytics on that data it was stupid. So, certainly looking back on it. So I think that was a huge contribution, feel good about it. And I'm glad that it's, continued to expand and really be a core part of optimizing quality and optimizing efficient translation from the bench to the bedside.
Do you have any thoughts on where we as a commission can work with our member organizations in terms of continuing to reduce variation and improve quality and safety, but also increase the value of the care that we provide?
Yeah, well, look, I'm still very active, even though I'm incredibly old, the big task. When we were at Geisinger, as hard as it might have been to do a lot of the transformation stuff that we did there, it was a heck of a lot easier to do it where we were, with the demography we had, with the brand that we had, with the fact that we had both a payer and a provider in the same fiduciary. And we got recognized for that, and I think appropriately so. The question that remained while I was there, and that I've been trying to focus on in my post-Geisinger transactions, is how much of that stuff can scale. And as you know, scaling innovation is much more difficult than actual innovation itself. And I got a couple of engines that we're using to look at scaling. One is a cooperative of very large self-insured companies called Health Transformation America. It's about 62, 63 companies. They range in size of 240,000 sponsored lives down to 5,000. And they've come together, and I've been working there since I retired from Geisinger to try to aggregate all the data from all of their sponsored lives to look at areas of variation. Variation is almost always a good surrogate for quality issues, to then focus in on the areas of variation to try to understand why frequencies in certain kinds of care are inexplicable, and then to see whether optimizing diagnosis and optimizing therapy is going to benefit patients. And as you know, Aaron, if you benefit patients, if you optimize their diagnosis and optimize their therapy, you save a heck of a lot of money. The cost goes down. So it's not like you have to focus either on cost reduction or you focus on quality. It doesn't matter. You focus on quality. And guess what? When you focus on quality, that's what turns on our colleagues who are providers. I mean, that's, and then a consequence of that is you get better outcome and you get lower costs. So, I mean, I would love to see, our 4.7 million sponsored lives in this country. We have another 3 million that are outside the country, and it's harder to get our arms around those. But I would love to see us at some point talk about how we can take those sponsored lives and our commitment in HTA to get better value, better quality outcome, and see whether we could work with the commission. I mean, that would be fun. That would be fun to look at.
It's funny listening to you speak now reminds me of the conversations we had back when we were at Geisinger, and the conversation that you had when you spoke at a CoC event that we had in Baltimore. But I need to keep hearing it because there's such a tendency to focus on the financial impact. And you're right, what gets people in the heart is focusing on the quality and the finance. I remember you saying this 2 decades ago.
Well, look, most of us as providers are really motivated by getting the best possible outcome for the people that we're responsible for, the people that we care for. And, I have great respect for providers. And I think in order to get better outcome, you've got to get providers moving in the right direction. And it's not just about, incentives are important, how you align incentives, it's kind of a predicate, a precondition, but it's really getting people, focused on improving their quality. That's what gets providers kind of charged up. And that's, I know that because I was a provider before I put a suit on.
I still remember reading your papers on transanal excision, among other procedures that you led research on. What do you think, in terms of direction the commission should go in the future to drive value? I mean, the 1,500 CoC accredited organizations don't have to remain CoC accredited. Their payments for cancer care are not impacted by their accreditation status. How do we keep them engaged, and what value can we provide them that will help them change?
Well, again, I think that some sort of a standardized way for looking at best practice, but not in a static, not with a static template, but with, kind of an AI philosophy where you get more data and then figure out how to improve. I think the CoC should be, Commission on Cancer should be an engine for that. That's the main. And again, I wouldn't, again, I think it's a provider-run organization, and I understand value-based care is going to move ahead. It's going to be it's going to continue in terms of the public payers, certainly, and a Health Transformation Alliance. We're going to be continuing to look at value, but for the provider side, and what I've said to my colleagues at HTA, who are, the CHROs of these big companies, the best way to get better value and to lower your costs is to have healthier employees, basically. So I think the CoC is in a perfect position to justify its next 100 years by continuing to be the engine for improving quality and for improving more efficient transmission of new knowledge to standard of care. Those are the two most important principles that I think will drive the commission for the next 100 years.
So surgeons aren't always the most patient people, and I find it surprising that we are now trying to hold surgeons accountable for making sure they do the standard steps in operations like sentinel node biopsy and axillary node dissection and total mesorectal excision, and that we haven't done it before now. And yet we're still, I think programs are very afraid of trying to implement these standards, looking at making sure we reduce variation in surgery. Do you have any thoughts about that?
Yeah, well, I think the trick on that, Aaron, is to, I mean, there's going to be some that are, there are going to be some folks that will never participate no matter what you do, obviously, and they I can't deal with them, but I think the trick in getting most people on board to improve their own quality is to have them, have them feel as if it makes a difference for their patients, and it may actually make a difference for, if they can input their own work into the standard setting that the commission is going to do, that it would make a difference for other patients as well. I mean, I think if people are made to feel as if they're drones, or if they're made to feel that, there's some quality police that's going to beat them up, that's just not the way I think you motivate providers, essentially. And I used to kid a lot when we did proven care, and we were trying to apply minimum acceptable standards for everything. I used to kid that when we applied that to hip replacement, knee replacement, that it was one of my charming challenges to deal with 25 highly productive orthopedic surgeons to try to get them to agree on anything. But now that I've moved into a different phase of my life, I got to tell you, working at Health Transformation Alliance, trying to get benefits managers to be innovative, that's an even more charming challenge than it was dealing with my 25 orthopedic surgeons at Geisinger. Oh my God. So, life's a challenge everywhere. What are you going to do?
Those perspectives are incredible. As Einstein said, everything's relative, right?
Exactly. If a benefits manager makes a single innovative move and there's turbulence in the company, he or she gets fired. So how's that for an incentive?
That's right. Inertia is a challenge for all of us, that's for sure. So any other thoughts that you have about those 3 years as chair of the commission that you think would be worthwhile to commemorate as we go into this 100th anniversary year?
Well, look, I met a huge number of incredibly committed people, some of whom moved into leadership, some of whom, were just really good providers.
Mm-hmm.
And that networking is, I mean, that sociology is incredibly gratifying, and the college again was a really good venue for scaling a lot of the stuff that I was committed to even before Geisinger, and then was committed to at Geisinger. And it was a wonderful part of my career. And I look back, on it. It was about the same time that I had a leadership position in the American Board of Surgery, and those things were all really great. It was terrific. And even when I put on a suit, and became a business guy, I think the fact that I had the honor of being a real provider and a real surgical leader, it gave me some credibility, even to guys like you. I mean, geez.
I read your papers before I met you, so that was... Well, I've always had an incredible amount of respect for you, and that's emblematic of the fact that this is the first tie I've worn in about 10 or 11 months. So.
Well, I certainly appreciate that.